Welcome, everyone. Thank you for joining today's virtual Sun session. My name is Caitlin Walker, and I'm a part of the marketing team here at Laerdal. Just a little housekeeping before we get started. If you have any questions during this session, please share them via the Q&A feature that can be found at the bottom of your screen. I'll be monitoring them during the session, and we will have time for questions at the end. To ensure you can see all speakers, select Gallery View. Recordings will be emailed to you after the session is over to watch on demand. Now, I would like to introduce our National Sales Director, Robin McCune.
Hi, everybody. It's my pleasure to welcome everyone to our fourth online simulation user network session entitled Creating a Culture of Readiness. As many of you know, we had to cancel our 2020 Simulation User Network conference this year, but that hasn't stopped us from serving you the way you've come to expect. Through the gracious help of our speakers, we're bringing you our content virtually, and we hope you'll sign up for the entire series. So far, we've had nearly 2,000 people attend the sessions. 2020 has been a tough year with all of us having to adjust to new ways of doing things. Your training objectives and stated outcomes have not changed, but the means by which you deliver your curriculums and training packages certainly have. Please know we're here to support you in moving forward. So on behalf of our entire organization, I'd like to thank you for being with us today. And now I'll turn this over to our moderator, Andrew Kostopik.
Hi, everyone. It's a beautiful day here in New York. I hope it's a beautiful day where you are dialing in today. Today's topic is training for COVID-19, creating a culture of readiness. And our guest speakers today to tell us about that topic is, first of all, Michael Smith, Dr. Michael Smith, the medical director at the Ochsner Clinical Simulation and Patient Safety Center, and Jacqueline Odom, the Director of Respiratory Therapy at Ochsner Jefferson Highway. So welcome both of you. Thank you for being with us today.
Thanks.
You're welcome. We appreciate you having us.
Well, we appreciate getting to know you all both on a professional level and on a personal level. So what we try to do with these is we just try to give the audience a little bit of flavor for our panelists and guest speakers, and we asked Michael and Jacqueline the question: what would you share with the audience about yourselves that they might not guess right away? And the first two things that came up were, and it's funny, I would have answered the first question the same way: our kids. So, Doctor, you have twins, correct?
Yeah, twin 12-year-old girls.
Right. So you have no fear.
Yeah.
And Jacqueline?
I have a 16-year-old boy and a 14-year-old girl, and the boy just started driving.
Okay. All right. And you're both boaters.
Yep.
And you both sort of threw yourselves into that cold turkey, right? Go ahead, Doctor.
I own a boat. She's probably more of a boater.
Well, again, no fear, right? Very good. So why don't we give you a chance before we begin to talk a little bit about Ochsner, and tell us about the Ochsner system down there in Louisiana.
So it's a large health system. It's the largest care provider in Louisiana, and it's got satellites into Mississippi. It's also probably, I believe it's the largest employer in Louisiana as well. So I came to Ochsner about just over 5 years ago. So a lot of the growth happened post-Katrina, but it's a multi-hospital system, multiple community hospitals. So it had a big role in the response to this pandemic.
Sure. Jacqueline, anything you'd like to add?
Yeah, I came to Ochsner a little over 5 years ago also, and I've been a respiratory therapist for 30 years. So got some time under my belt, but I've been blessed to be at Ochsner. I'm just very proud of their core values. You know, one thing is definitely teamwork and integrity and patients first. And patients first is the first thing we think of. And that's why we all do what we do. So I think Ochsner was, we didn't feel prepared, but I think we were prepared for the pandemic. And definitely, I think in the future we'll be talking about Katrina, but I went through another system in that that situation, and I'm very proud to be here.
Awesome, thank you. So let's talk about just very briefly why we chose this topic. 2020 has been a year of endless alert, and it's almost been like a crazy game of healthcare whack-a-mole. At one point, you think, okay, we're over the curve, we're starting to level off, and then a flare-up somewhere else. So that state of alert is no doubt tiring some people out, but we have to be prepared. So we're going to get into that in a moment, but before we talk about preparedness, we're going to ask a polling question. We're going to ask our audience a question. So for everyone online, a question just popped up, and we'd like to get your response. So the question is, as we look at 2020 and COVID-19, do you believe your institution is training effectively to maintain a culture of readiness? And you've got 3 choices there. So yes, watch me show you how it's done. Mostly, but we have room for improvement, and no, and I'm concerned. So we're just going to wait a moment. We're going to ask everybody to please answer that, and we'll see what the results are. That's important to give our speakers an idea of where everybody's coming from in our audience. And I'm putting money on, so well, that's pretty good. So 75% of the people in the viewing audience have said mostly we're prepared, but we have room for improvement. Then there's another 22%, or I'm so sorry, I stand corrected, another 18% that say no, and I'm concerned. 7% say we got this. So they're here to compare notes. So let's move forward. Let's move forward to what drives a culture of readiness at Ochsner. Jacqueline, you just mentioned Katrina. Your environment is a little different than many of the environments in the U.S. Let's talk about how that impacts your culture of readiness there.
So when Katrina hit, it was not my first hurricane to have gone through as a healthcare provider. But when it hit, we never expected what it delivered. We didn't expect to be out for 2 to 4 weeks without power. So there's a lot of things that we did not expect. When you prepare for a hurricane, the one thing about a hurricane is that you can be, you know, it's going to hit you today. It might still linger tomorrow, but afterwards you expect you're just going to get the cleanup, you're going to get yourself ready, and you know what to expect from there because you've already prepared yourself. If it's devastation, we can fix it, put some walls back up, and you go with it. And when we prepare in healthcare for a hurricane, we do have to prepare for anywhere from 2 to 4 weeks of not having water, not having power, not having food delivered. So I guess in the respect of Katrina, we always stay at a ever readiness of preparedness. We have to, especially since Katrina, because it was one of the biggest ones since Hurricane Camille. That was the most devastating. And when I was told that we were going to start watching the COVID, and when we were kind of looking at the progress it was making coming into the United States, when they told me that, you know, Jackie, we need you to prepare for 100 ventilators, I said, nope, we're going to prepare for 200 ventilators. Because my normal ventilator capacity, my average is about 40 to 50 ventilators a day. So I just had that mindset of Katrina, or that mindset of the biggest devastation ever. And so now we do have to prepare for whatever's bigger than we've had in the past. But if you're not prepared, And if you're not even trying to prepare, then you're going to find yourself in a kind of a pickle.
Sure. Doctor, do you have anything to add to that?
So I wasn't here in the Gulf South during Katrina, but from adjusting to and preparing for hurricanes, we've had a couple near misses since I've been here. And the thing that stands out is there's this, sometimes it feels like it's a little bit too much at times, but there's this very thorough communication to all people. And there's plans for, like at least clinically, like in the emergency department, we have teams that would be activated, and then a relief team for people working through the hurricane, then the people that would relieve them. But that's just sort of the mindset, and I think that just being prepared in that way gave them a little bit of a jump on preparing for this as we start to see this increase in the Louisiana area. So if you remember, we saw sporadic cases in the United States, definitely in January, but probably as early as December of last year. But we started to see spikes that were concerning a couple of weeks after Mardi Gras
Sure.
ended. So if I remember correctly, it was the day after St. Patrick's Day that we got notified that the schools were going offline.
Right.
We're going to go to virtual learning. So we very quickly had to sort of ramp up and prepare for that.
So, so you're just by virtue of where you live and your past experiences, and for listener benefit, when we look back at just the last century, 6 hurricanes have actually hit New Orleans. And while COVID is different from a hurricane in a sense, it's not, because you still have to prepare for that overwhelming number of patients coming into the hospital.
Right.
Before we continue, because we're going to turn in a moment to how you reinforce your culture. You'd mentioned culture and values early on. I want to remind all our listeners, please put your questions in the Q&A feature at the bottom of your screen, because we will have 15 minutes or so at the end of the session here to take your take your questions. So I encourage you, please put your questions into that Q&A, and we will get to them. We're seeing some good chat going on, and apparently we're going to be credited for healthcare whack-a-mole as a new term that's going to go viral today. So so let's move ahead. Let's go to advice you might offer others on reinforcing values, reinforcing culture when you're doing your training, because you all didn't waver one bit during COVID-19 from those core values. How do you work them into your training? And if you want to offer how you work those into your daily your daily efforts to make sure that you're reinforcing the values there at your institution.
Well, I think when in that middle of March, when things started to ramp up, the simulation center never shut down. So we had we put protections into place. We immediately started masking people and ensuring distancing, things like that. So our group sizes decreased and the number of groups increased. But we kept going. So we, as a system, the simulation center touches pretty much every type of employee that goes through the hospital. So we have obviously physicians, nurses, all nurses that get hired at Oxnard go through the simulation center. We have respiratory therapy, obviously. We have a medical school partnership, a PA school partnership. So there's all these types of, we even non-clinical learners, we've been putting through the Sim Center for communication courses and stuff like that. So a lot of the stuff had to keep going. We did, in our response, probably tailor some, if we were teaching any kind of like a critical care training, we tailored it with COVID information as well, and PPE information. But in terms of advice for preparing, I mean, you need top-down buy-in of being prepared for this.
Sure.
And fortunately, we had that here within our system. And even, you know, just simulation in general, I never really had to argue for simulation at Oxnard as I have at sort of past institutions.
Sure.
You know, demonstrate the value of it. It was pretty much known.
And I'd like to ask some questions about that a little later, because that's a good topic to explore for a few minutes. Jacqueline, anything that you saw, and I'm kind of curious, did your learners and your staff notice a drastic change, or was it fairly seamless for them as you had to, for example, increase the quantity of sessions but reduce class size or group size as you're going through your training?
So, as most of you know, that COVID is a respiratory disease, and it hit the respiratory therapist probably like the ED as hard as they could get a hit. We were unable to even attempt to go into the simulation center at that time because it was all hands on deck. So we didn't have because my RTs were working sometimes 10 days in a row. We did a lot of our training. If we had to do immediate training, we did it at the bedside or in the hallways. So we had to make a little bit kind of a different approach to training. But and anytime Dr. Smith or any of their team called because they needed assistance, we would go over and certainly help their teams to do any learning that they needed to do. But unfortunately for us at the time, we were not able to go to the Sim Center. We just didn't have the staff to do it. But I'm just super, super proud that Dr. Smith and his team were able to keep it going because there were so many things that had gotten shut down and so many people had lost their resources. So we are very, very lucky that we had the resources available. If I needed to run to the Sim Center and teach something, it was available for us. But, you know, just my RTs going in there during COVID, that was impossible. Prior to COVID, we had probably 4 or 5 simulation center days. One of my supervisors would go over and she would have RTs in the Sim Center teaching, doing kind of a live bedside learning with the team. So that because when I came to Ochsner, we didn't have an education program for the respiratory therapist. So when we got here, that was the one thing I wanted to do first. And when Dr. Smith approached me, or I can't remember exactly who it was that approached me and said that it was available, I'm like, I'm all in. So we, you know, like he said, he didn't have to ask me to come to the Sim Center. He just said it's available and I jumped on it. But the fact that we had done some bedside learning and put our team under a little duress just in the Sim Center, I think really helped a little bit at the bedside because they had that bedside learning. It just seemed normal, I guess.
Once I turn my microphone back on, I'm going to sum that up. If I could write one word that you've reinforced, and it comes out clear, it's come out clear in our previous discussions, it's resilience. It's very clear that that one of the ways that you reinforced your culture during the training is just not to stop, and we're going to get to that in a few moments. We're going to cover that some more, but you were definitely default forward, and default aggressive in your approach, and that's inspiring. So let's turn now to some of the specific areas that most people online are concerned about. So they're concerned about intubation. They're concerned about, well, they're concerned about PPE. They're concerned about intubation. They're concerned certainly about ventilation, vent care, and then of course there's extubation and the potential for having to perform tracheostomy. So how did you, I know this is a very fluid situation. How did you cope with all of that? Especially as new guidance came down the line, or new directives, new discoveries. Whoever would like to take that, Mike or Jacqueline, go ahead.
I'll
Throwing
let
the ball in the
Dr.
air.
take that one first.
Sure, sure.
I think it's, for being an emergency physician, I think it's sort of just par for the course. I mean, it's anyone, anytime, anyhow, and you just sort of plow through. I can say that we ramped up, obviously, as we've discussed, preparations for the pandemic. But fortunately, we didn't get to the point of running out of ventilators, running out of PPE. There were obviously sick patients, but thankfully not to the point of like that we initially prepared for. So thankfully, we over prepared for that situation. There's some additional stressors in dealing with the pandemic. I mean, on a normal day, I don't walk into rooms with full body PPE, but we have frontline providers that are, dealing with the stress of getting infected, or having to be taken off the team for a couple of weeks. And that was a situation that changed as we learned more about the disease as the pandemic progressed. So we refined those protocols as well. Part of it's thankfully the circumstance and the preparation, but some of it's just sort of that mentality of you keep chugging along.
Sure. Jacqueline, you were about to say something?
No, but I agree with Dr. Smith. Coping is something that each one of us have to learn how to do individually. But the one thing that I have to say is that our leadership team really helped us cope through this. So they were willing to listen. They were willing to help us in anything that we needed. So I never experienced, I'll speak for Dr. Smith, but I never experienced if I said I needed, they didn't do, or they didn't try some way to get it done for me. But our teams, you have to be on the ground with them. So interestingly enough, you show this picture, and I don't like to see pictures of myself, but I hate seeing pictures of myself. But anyway.
Dr. Smith sent it.
Yeah.
You're
but
welcome.
this, right? Yeah, really. I'll get you later. This picture, I'm actually teaching it, like, again, I'm in the hallway, and 30 years ago, our technology wasn't there that we have now. And this, a V60 BiPAP can be turned into a ventilator. So when we were at the time of, we might go low on vents, we had to figure out what to do, because we were not going to put people on, 2 patients on 1 ventilator, because that's putting 2 patients at risk. And we just are not willing to do that. So we had to figure out other ways to make that happen. And this was one of them. So, just simply using old technology in today's digital world, sometimes it's hard to do, and it's hard to get people to understand that. And when I brought this vent in there to the bedside, the physicians were a little nervous. They're not used to seeing that, but we worked together and we communicated what we were doing. And I said, this is not going to look like what you used to seeing, but it's going to do the same job. It's just a different car brand. That's all it is. So but coping is something that it's hard to do. And I think with us that live down here in the South that go through these hurricanes on a yearly basis, and we prepare, we're constantly in this state of preparedness. And I honestly believe that really helps us to cope with anything that comes at us.
And I think the institution also, like she was saying, was really supportive. Again, it's, I believe I'm correct, it's the largest employer in Louisiana. So fortunately, we were in a position, both financially and through our leadership direction, that we didn't suffer the layoffs that other institutions had. So the Sim Center participated in some redeployment training, and then there was just redeployment that happened outside of the Sim Center that was just planned. So services that got shut down or minimized got shunted into other things. So we fortunately didn't have people going unemployed from Oxnard, the same way it was felt across the country. And even I say little things, but they're not really little things. School shut down in March, and Oxnard, I think they started on a Friday, and by Monday they had a plan for 1,500 spots for kids to go into a day camp, so their parents could continue to work.
Pretty incredible.
Covered by Oxnard for their employees.
Pretty incredible. Before we move to the next slide, I want to just stay here for just a moment, because you have that culture of preparedness. You have a culture of readiness, very much because of your experience with Katrina and where you all live. But for someone that doesn't, we know that if we were to look at, for example, the New York experience, was very much an experience where they had to really ramp up for training on intubation. They had to get many more people trained up and fast. Same with vent training. Then many discovered that, okay, 14 days down the road, let's say, a patient had to be extubated, and that now brought on a whole new subject for training. You all were pretty much prepared for that, but are there things in your training program, let's just take intubation, for example, or take any one of the subjects. Are there parts of your program that you would recommend to someone else who is preparing to experience a rush of patients, or maybe in the middle of that, that you would say zero in on, because this had us prepared when COVID struck Louisiana?
So in terms of like intubation, the topic came up before about not having the staffing to perform the intubations, and that was a concern. But fortunately, as I said before, when we had certain services that were scaled back due to the pandemic, so we weren't doing elective surgeries, those anesthesiologists and nurse anesthetists and stuff, they were moved into COVID units and redeployed in other ways. So we never felt that. I mean, you would see like a cardiologist going into the going into a unit to take care of ICU patients. There may be a redeployment like that, but not
Sure.
to the extremes of what some may have felt in other areas. We fortunately, we focus a lot in the Sim Center on team training, and a lot of both through nursing and through graduate medical education on recognizing the decompensating patient. And there's a lot of technological advances outside of simulation, just on across the street in the hospital, and monitoring the patient and communicating a potential decompensating patient. So there's lots of steps in in there that are a little bit safer for the patient.
So would it be safe to, Jacqueline, I hope I didn't interrupt you. Would it be safe to say, so I heard two things, team training, and then redeployment of resources. So if I'm someone that wants to make sure that I'm prepared, if I'm part of that approximately 75% that feels they have room for improvement, or the others that really are concerned, that might be two areas you would suggest, is have a plan ready to redeploy assets within the hospital, and then also focus on your team training.
Yeah, and there's always the potential that you could develop programs for maybe a physician specialty doesn't intubate as much. Again, we didn't have that specific issue here at Oxnard, but with another system, you could put in programs to sort of put them through that training. There's some specialties that I could think of that, they might not have like central line training recently, that you could put them through that. And we have programs for that too. But fortunately, that was not something that we really had to ramp up too much through the simulation center.
So I would, I'm gonna piggyback on that a little bit, because I think the two things you talked about was deployment or redeployment and training. So number one, I believe that you should have everyone who is at the bedside needs to practice in their role, which is something that Dr. Smith and his team does an amazing job of. So instead of having a physician be a respiratory therapist, they're going to have the respiratory therapist be the therapist, and then the physician will be the physician, the nurse will be the nurse. And what that does is it helps build that team component, because if you train that way, then it's normal and it happens. The other piece to that is I think that we have to remember that everyone that has a professional license has a license with certain capabilities. For example, in some areas, RTs don't intubate, we don't put in A lines, we don't monitor central lines. There's a lot of things that your professional license allows you to do, and you should teach up to that. And for example, Dr. Smith allows us to come in and use his intubation. We don't intubate, respiratory doesn't intubate in my current, I got 3 facilities, but one of my facilities, because we have a lot of students that do it. But if I need an RT to intubate, they know how to. So it's never even a question of, can I train them? No, they're already trained. We can teach. We may not do it every day, but we can teach to it and we learn to it. So I think that's another thing that people need to remember, is that everyone needs to work to the top of their license so that the next person can work above and beyond their normal license as well. So having that team component where we're all in it together, it's huge. It's huge. You can't do it in silos.
Outstanding. So let's look at the payoff. Let's look at an example. So this story. Well, let me tell it. This is your 1500th patient. This photo was taken on April 20th. This is your 1500th COVID patient that had been through your system and is being discharged. And I have to tell you, it's hard not to get choked up. And if anybody online is getting choked up, well, I salute you, because this photo deserves to get people choked up, I think. 1500th patient on a ventilator for 12 days with COVID, and voila, this is the net result of doing it right. Everything that you've been talking about with team training, individual preparedness, keep people performing to their max. Here it is. Here's the payoff. So yeah, we salute you for your
If
great
you,
work.
if you saw the video of this, they're second lining behind her. So that's a jazz band behind her, following her out. And it's a huge celebration. This wasn't at our facility. This was at our facility in another city. So, I mean, we're a system, we're all one.
Sure.
But, you know, it's amazing that we get to celebrate such things. And I don't know, you're right, I get choked up, and I'm not going to cry on camera. Not today.
Well, we wouldn't blame you if you did. I mean, it's really
No, I'm not
really a
going to do
compelling
it.
story. Yeah, it's
And
really
it's really important when you get to the point of needing intubation on a ventilator with COVID. The mortality across the country has been pretty high, so that's a pretty good comeback.
well, that definitely is a fist pump moment. So, thank you for what you're all doing there. So let's dive a little deeper into your ventilator training abilities. And you did some pretty interesting things with proving out processes and looking at different options for how, if you had to cope with an overwhelming amount of patients. Tell us how you approached all of that and proved out some of your processes and things you did with your vent training.
So early in the pandemic, we were obviously dealing with a lot of unknowns and patients that had the potential to develop a severe respiratory illness and failure. And even before that, there's a subset of patients that can develop profound hypoxemia, but they're still not in significant respiratory distress. So we were dealing with those patients coming in, along with the concern of how do we keep everyone safe in the acute care setting. So we were reluctant to use non-invasive ventilation on these patients early on for fear of aerosolizing the virus. We would not use nebulizer treatments for fear of aerosolizing the virus. We would give them, the meter dose inhalers. If we were going to give them albuterol until the point that they were intubated and on a closed system. So as the situation evolved more and we started to learn more, we probably ended up intubating less patients. I think that's true across the country, and using other means to save them from going on the ventilator. In terms of ventilator training, so we have the capabilities with the ASL to mimic what we see in COVID. So that gives our team the ability to not just sit at a board and talk about changing the ventilator, but they can actually manipulate the ventilator. So we did training around that. We did training of trying to do this with the appropriate PPE on. So we incorporated that into our training. Not so much the ventilators, because it would be hard to do with the tubing, but certain machines were moved out into the hall where you could monitor and respond to alarms without having to cross the barrier into the room. So there were things like that. The intubation and respiratory care, we tested barriers for that. So there was some like innovation testing in the Sim Center, including that we took some dye and put it in the aerosol and let it go on the room, and it didn't actually go as far as we were suspecting. But things like that sort of update the information as you go along. But we tried to be proactive in it. They were ramping up ventilators to be maximally prepared. I know that it wasn't an ideal situation like she was mentioning, but we, through our 3D imaging team, we printed a splitter if we got to that point. But it was just sort of to give you an idea. This was the culture of the institution. We were exploring all angles. What if it goes to B? What if it goes to C? What if it goes to D? What if it goes to E? What are our backup plans?
I think to the overall umbrella of that applies to what you're doing is you're testing everything through simulation before you put it into practice, and I think that's compelling. Jacqueline, you're nodding your head, so if you want to jump in and add to that, go for it.
No, I find it, I'm just super proud of the fact that we can do that. I've never worked for an institution that had this capability, and I'm just super proud that we could do that. And the fact that, that our leaders allow us to do it, allow us the time to do it. And we have folks like Dr. Smith, Natalie, they invite us in for things that, some people don't get invited to. So we get to experience it with them, which makes it even that much better. So
again, and the outcomes are, the proof is in the pudding, right? So let's move to, so now you've got this, since you're already testing so much with simulation, let's look at what you'd recommend to create the ideal COVID readiness scenario. And Jacqueline, you talked about one factor that you want to train people to, and why don't we begin with that, and then Doctor, if you've got something to add as well.
So I'm not gonna say we need to train to COVID. We need to train beyond COVID. We need to train beyond the next hurricane. We need to make sure that when we're training, and I always think about it, like a firefighter never goes into a home that's on fire without having been in that situation in a training in a controlled environment. Military, we train our military teams to be shot at prior to us going and get shot at. So in order for us to have our teams ready, we have to be willing to put them at some level of unease. If you can call it stress, you can call it whatever you want to call it. But in order for somebody to learn and to remember, you have to have that anxiety in having to think while you're at that level of anxiety. It doesn't have to be great. It can just be a little bit, just enough to make the hair stand up on the back of their necks. But we have to have that ability. You have to have that ability to be able to train to that. And I'll tell anybody, I was a teacher for 6 years of respiratory therapy, and I had very, very, very little equipment. So we made equipment. We pretended that there was a person at the bedside, and I made them get nervous. I stood over them asking them questions, just like the physicians would be, in the room. So you don't have to have these elaborate sim centers. You don't have to have these elaborate sim dolls. You could have the minor one, but you still will be able to create that ability for them to learn. People have to be in those situations in order to learn. I will never, ever forget, and nobody in this country will ever forget how you felt when the first COVID hit the door. I know Dr. Smith will never forget that either. So that's where our learning comes in. So if we prepare our teams to go to the next level of COVID or go to the next level of hurricane, then when it happens, yep, guess what? The next time we're going to have to train a little bit harder because it's going to be worse than the last one.
Sure.
So you just have to continue to keep that level of readiness and that training going so that it's constant. Not only will you, I feel that not only will you just have that training level, but you'll have that buy-in too. Because I think when our teams came in and they were like, what just happened? We're like, okay, it's all good. We got this, and you've done this. We've trained for this. And it helped them a little bit. Now, everybody was still uneasy. It didn't matter. We were nervous. We were scared. There's not one person that'll say that they were ready for COVID to hit. You can never imagine it. I'm sure this felt like the polio or the TB, back in the day. And so that's just my thing. You just have to train for it, and you got to teach your teams how to have buy-in, and it's very difficult. I will add that. It's very difficult.
Doctor, you've got a saying on your door.
Yeah, that it's a common philosophical saying, but it's in times of crisis, we don't rise to the level of our expectations; we fall to the level of our training.
Right.
Exactly right.
And that's you see it in real life too. So we try to, as she was saying, we try to find this optimal stress level when teaching. You don't want, as I joke around frequently, you don't want people laughing in the room and not absorbing anything. And there's a physiological theory about certain areas of brain activation that actually make learning a little more heightened when you're stressed. But you don't want people rocking and crying with like PTSD after you put them through a simulation. You're not going to get them to come back.
Right.
So we try to balance that. But in terms of how you would prepare someone, I mean, it's all the entire continuum of care. So when they show up to the emergency department, or we're fortunate our center, we built our center to teach transitions of care. So I could take them through a clinic to the emergency department, to the operating room, and then back into the ICU. So we can do all those transitions. But it's not just the clinical care. I mean, so there's the intubation of the critical patient, but how do you manage the vent? How do you manage their volume status? How do you teach someone to don and off PPE appropriately?
Sure.
How are you going to handle visitors to patients? Are you going to restrict all visitors except in like the near-death situations or the actively dying patient? Are you going to let limited family in? Are you going to put them in PPE? Are you going to teach someone how to put PPE on someone else, which is more difficult than it sounds? If you've ever had to tie a tie on someone else, it's not as easy as it sounds.
So all of that you wouldn't want to do as OJT, right, on the job training. You'd want to do it. You'd want to do it in advance. And that comment you made about continuum of care, add into that a little bit of stress inoculation theory and amping up everybody's game. Those are all worthwhile points as people think about the scenarios they want to design. Let's. We've only got a few more questions before we get to audience questions, but let's quickly talk about debriefing. How do you approach it? How do you like to approach it? What are your comments, please?
So it's a little bit long-winded topic for me, but I'll try to just be brief in it. It's obviously it's important. It's as important or even more important than the actual simulation scenario. So this is where the learning happens, okay? And one of the big skills that you've got it's a skill, okay? So being a content expert doesn't mean that you're skilled in debriefing yet. You've got to be trained in debriefing. So we've seen situations, all of us as a content expert, and the learner walks in and they say, what did you do wrong? And that shuts down the debrief when you say something like that. So it's learning how to debrief, learning how to sort of hold back and not monologue and teach. A lot of people in healthcare, they just want to jump in and start lecturing, and you've got to hold back in that. And the concept really is that you don't really get at watching the simulation or watching a video of the simulation. You can only record and checkmark behaviors. You don't get at why the behaviors happened or didn't happen until you debrief. So someone may have done the right thing in the simulation and gotten their check mark, but done it for completely wrong reasons that you find out. or they may have withheld from that behavior for perfectly logical, reasonable motives. So the debrief is really, really important. And I think this came up when we were talking previously about we've tried to incorporate virtual simulation and sort of remote training as much as possible. So all of our didactics, at the beginning of the pandemic, we didn't bring people in and congregate them for a lecture. We moved all of those to a remote platform such as this. And then the virtual simulations, the key thing is it's not just showing a video. So it's great to get in and get a hands-on experience, but I would say that a true virtual simulation is more to the end of an in-person simulation than just watching a video and taking a multiple choice test, like an online learning module. Because you can still watch that even if it's someone else's actions and then debrief them and say, why do you think they did that? And you can get at sort of the frame of those behaviors.
Sure.
Sorry if that was too long-winded.
No. It's excellent. Thank you. And Jacqueline, I want to offer you any opportunity to comment because you've probably run debriefings. You've probably been on the other end of a debriefing. Any other comments here or suggestions for people?
No, I think Dr. Smith said it well. You just have to train to do it. It's uncomfortable, but once you get accustomed to taking feedback, giving feedback, it gets easier. But it is uncomfortable because he's right. You know, you and I might get the same answer, but we may not be going at it the right way.
Sure.
So you need to be able to accept the fact that you did it, you went to it the wrong way, I guess. But no, I agree with everything he says.
Excellent. So I'm going to, in the interest of time, I'm going to combine the next two slides. So we'll just stay right here. But looking forward, looking into the future, you've already commented on some of what you did with virtual training. And if you'd like to comment more, feel free. But looking ahead towards the future, what advice would you give people? What ultimate lessons learned can you glean from your experience that you want to pass on to people so that they can keep training moving forward through these times?
I think the lessons in general were similar to what we were doing prior to this. So in general, we try to, when we bring them a learner in, we try not to give them the feeling that we're wasting their time, so that we value their time. So one of the things, like I said, the pandemic has sort of forced on us is that you don't really need to congregate to sit and look at a PowerPoint. That can be done remotely and as part of pre-work. I think those sort of principles are still the same. One of the things when we were talking about debriefing, the content expert, it's important that we not rely just on a single content expert. You want to bring groups in, so there's sort of some interplay between the instructors, because it's important to understand, like we always say, practice makes perfect, but it's perfect practice that makes perfect. So you do want to avoid a situation, fortunately you don't see it a lot, but you wouldn't want an instructor that is not up to date on the latest in their field and sort of passing that dogma along without sort of interplay with other people in their field. So, but I think we've been doing that even prior to the pandemic. People like, it seems they like the virtual learning a lot. So I think that's been successful. It seems like the students would much rather Zoom in for their lecture than drive-in.
I would
Go ahead.
add, I think I would add that, we brought in the RTs doing things at the bedside, and, at first you always get this standoffish, I don't want to do that, I don't want to do that. But when it's not there, they're like, well, why can't we do that? Because they felt like they learned it. And there's some things you can do virtual. Yeah, didactic classes can definitely be done virtual. But I truly, honestly believe in the hands-on experience, sitting there thinking, and that's how you build your critical thinking skills. But I would just continue to move forward with whatever training you can do in person. Keep your distance, do what needs to be done, but still try to incorporate a little bit of that. And we still are.
Excellent.
I would say in general, even pre-COVID, I mean, the way you design scenarios is that you identify the need, then you write learning objectives based off that need, and there's a skill to writing learning objectives, and then the case builds itself around those learning objectives. And I can say from experience that we tend to, especially new people to simulation, want to cram a lot into a simulation versus just focusing on 2 or 3 learning objectives.
Sure.
But I think those are things that are still the same now.
And cramming a lot in is a good segue to what we've done today. So what I want to do is we're going to fast forward to some audience questions.
Okay.
And we're going to go by the polling question today, but we're going to go straight to the audience questions. So we've got one question here. Now this gets back to intubation. Did you simulate intubations or other aerosol generating procedures in the sim center? And what can you tell us about that process? So I know you covered in situ, but just to make sure we've answered this question for this guest.
So we, yes. So we deal with multiple learners. We do team training and discipline training. So the most accurate answer would be it depends on the scenario. But we did do training with PPE coverage. One of the things that with intubation is that fortunately, when I go in to intubate someone for real in the emergency department during the pandemic, I wear full PPE and a self-contained helmet, like a PAPR's device. And we've also noticed that we shunted a lot more towards video laryngoscopy. So that's something. Because you're not putting your face down by the patient's mouth for the direct laryngoscopy, you can actually do it with your body turned and do the procedure. So that's something that you may incorporate into the intubation training, along with just doing the training in general. I think you're coming through muted.
You're on mute, I think, Andrew.
I'm so sorry. So this next question is about reopening your PFT lab post-COVID. The guest here is following CDC and infection control recommendations, but they'd like to know what other facilities are doing. Any comment?
Yeah, we've opened up our PFT labs. It's been a good bit since we've opened them up. And we're doing all the right things. We're wearing PPE appropriately. They're being tested prior to coming in. At all entrance sites at our hospital and clinics, you have to be tested for, fever, whatever the guidelines are. But we've opened it. As a matter of fact, I'm sitting in one of our PFT labs in Morgan City that's just not being used because it's lunchtime. But we go in and clean the equipment appropriately. And we're just taking all the right precautions. And as long as you're taking all the right precautions, you can still provide good care to your patients.
All right. And one last question, and I know we're almost at the top of the hour, but debriefing. Do you have any recommendations? Now, this sounds like it's coming from a nurse training program, but do you have a recommendation for transitioning to debriefing for meaningful learning? in a practical nursing program. So this is for students that are experiencing simulation for the very first time.
So there's obviously several different models that you can use for debriefing. So there's depending on the type of learning you're doing, it doesn't necessarily have to be like a big involved model. You can use if you're doing, like, for instance, a checklist procedural learning, it's okay to say, what do you think went well? What do you think you would change, like a plus delta? When you do the more immersive, involved simulations, then you would use the techniques of like inquiry and reflection and stuff. And there's multiple lectures and resources on the topic. And if anyone, I'm happy if they email me. I'm happy to share those with you.
Okay.
Or try to point you in the right direction.
And there's also the Enaxle best practices for anyone who's in nursing education. Certainly follow those. So we're unfortunately going to have to call it a wrap. I'd like to continue for another half hour at least. So thank you both, Dr. Smith, Jacqueline, thank you so much. We'd like to make sure everybody's aware that on August 5th at 2 o'clock Eastern Standard Time, we have a follow-up to this webinar, Advice for How to Implement a Best-in-Class Respiratory Training Program. So a lot of what you heard about today, we'll have some of our own educators online to talk about that. So again, Jacqueline, Dr. Smith, thank you. Folks are seeing some of our resources online, and you'll be able to see this recording in approximately a day. We'll have it up on our Sun webpage. Please follow us, please register for the series, and we thank everyone out there for dialing in today. It's been a great hour, and thank you all for participating. Have a great day, everyone.
Thanks, you too.
Thank you all, guys.